Hi, I am Dr. Avijit Moulick, consultant cardiologist from Kolkata. Today, I will briefly discuss some latest updates in hypertension. High blood pressure is among the most important risk factors for CVDs. As per WHO, nearly two-thirds of total deaths in India are due to non-communicable diseases, of which more than 27% are attributed to cardiovascular disease, which affects 45% people in the age range of 40 to 70 years. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and a very poor follow-up among the patients. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% of the similar values respectively. And this is a WHO data. Despite that, nearly half of the people with hypertension were unaware of the condition. Additionally, over 62% of men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1/5 of men and 1/4 of women with hypertension worldwide. So the scenario is similar all over the world, and it is worse in India. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigms attempts to address the issue in resource-poor settings. Optimal care refers to evidence-based and ideal standard of care, and essential standards refer to minimum standards of care in low resource settings. The ACCHA has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension of the ACC-AHA classification, where the blood pressure is systolic 130 to 139 and diastolic 80 to 89 millimeter of mercury. So they said that among low risk adults who doesn't have any atherosclerotic cardiovascular disease or a 10-year CVD risk less than 10%, with stage 1 hypertension, management starts with non-pharmacologic therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. So the blood pressure should be controlled with lifestyle modification and diet in some low risk ASCVD patients whose blood pressure in the 130 to 139 and 80 to 89 millimeter of mercury category. And this treatment should be followed by pharmacological additional treatment if the blood pressure doesn't come in the range of normal blood pressure by 3 to 6 months. Acute respiratory distress syndrome in a potential fatal condition involving lung damage, and experts often associate it with severe COVID-19 infection. A recent study which appears in the Journal of American Cardiology, College of Cardiology, reports that metoprolol can reduce lung inflammation and improve respiratory function in people with COVID-19 induced ARDS. Further studies are required to see what is the effect of metoprolol on this particular condition. Lowering systolic blood pressure targets down to the 110 to 130 millimeter of mercury range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming the sprint findings for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target reduced 26% of the composite cardiovascular risk. Findings from now a second major trial, so step after sprint, 2 major trial supporting the lower target, could ultimately unite the guidelines where the normal blood pressure target and stage 1 hypertension target does not coincide. Even in the United States, several professional societies give their range of normal blood pressure from 130 to 150 millimeter of mercury systolic. Now, with regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European guidelines on the management of arterial hypertension recommend The diagnosis of hypertension should not only be dependent on office blood pressure measurements, but also on out-of-office measurements such as ABPM or home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating cardiovascular risk. For every 20 by 10 millimeter of mercury increment of blood pressure measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. So the detection of the nighttime blood pressure and 24-hour recording of blood pressure are becoming more and more important in the management of hypertension. And with the available gadgets, now this has become a reality, and office blood pressure measurement should not be relied upon singularly for outcome purposes. Most patients with hypertension require lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommend 5 classes of antihypertensive drugs. Considering high prevalence of non-adherence to the treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of either ACE inhibitor or ARB plus CCB or a diuretic. And this is more so in case where the patient is first prescribed medication in a stage 2 hypertension. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen NDMA, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Zhejiang, Huai, the manufacturing site where the highest levels of contaminants were found, every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime. And the presence of NDMA in these drugs would lead to 8 additional cancers in 1 lakh patients if they are taken the highest dose over a period of 4 years. So valsartan recall accompanied by a significant increase in the rate of emergency department visits because it constituted an important therapeutic armamentarium for the management of hypertension. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual morning therapy upon awakening exerts a favorable cardiovascular risk reduction. The largest study, it included more than 19,000 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary cardiovascular outcome. An ambulatory blood pressure measurement was performed for 48 hours to collect data on how BP differed during sleep. The relative risk reduction for cardiovascular events was significantly improved for nighttime treatment when compared with awakening treatment. So this study was quite a large enough to prove that probably nighttime blood pressure control is more beneficial than usual morning prescription of antihypertensive drugs, and this should be practiced in a larger way. So with this, I conclude my talk. Thank you for listening.